So we will move to the next topic, which is surgery for the pediatric and adolescent chronic pancreatitis, any different from the adults. For this lecture, I would like to invite Dr. H. Ramesh. He is a renowned surgeon from Lakeshore Hospital's Cochin. I think he is known to this August gathering very much. Over to sir, please.
Thank you very much, and thanks to the organizers for this opportunity to participate in this meeting as a speaker. The task seems to be to look at the entity of pediatric or adolescent pancreatitis, which is essentially something under 18 years. But in passing, it is difficult to remain in the hall and listen to tales that if surgery is done, all patients will come back with pain. Surely that's not a subject that anybody can get away with, and I have to take issue with Dr. Sethi that he has to come and do the follow-up personally and see patients 20 years later and pain-free. So it's not really okay to make lordly statements like that. The format of my presentation is to try to look at the characteristics of childhood pancreatitis and the similarities between childhood and adult pancreatitis, to see the differences and to see how one can approach the young, and to summarize our experience and also the experience of some others. The causes usually are acute pancreatitis leading to chronic pancreatitis, and it is now regularly accepted that most causes of recurrent acute pancreatitis do end up with chronic pancreatitis. It used to be said that biliary does not, but if there is ductal damage, then it can. Trauma itself can produce obstructive pancreatitis. Ductal strictures due to a previous acute pancreatitis can produce ductal disconnection and chronic pancreatitis. The idiopathic or tropical pancreatitis is a specific entity and needs much attention. Whether or not pancreas divisum produces pancreatitis is a moot point. This is a typical ERCP picture of an arborizing ventral segment and an accessory duct cannulation showing you a dilated dorsal segment. If there is going to be chronic pancreatitis, it will affect the dorsal duct. But pancreas divisum per se does not necessarily predispose to chronic pancreatitis. I wish to emphasize this entity, that if you have either trauma or if you have acute pseudocyst, and if that produces upstream ductal changes, this is a condition of obstructive pancreatitis, and all of us need to keep our eyes open for this condition, because if in these conditions there is little or no fibrosis, little or no calcification, and little or no functional loss, and the benefits of drainage are supreme and long-lasting. I'd like to summarize the adult versus childhood pancreatitis as we see in most parts of this country. Obviously, the children are younger. Malignancy has not been reported in young children. There was many more females among the children. Obviously, functional status was better, diabetes was less. Obstructive changes of nearby tubes were less. No chance in children, more female children, and less functional loss. Therefore, there was less steatorrhea. Although 72% only had calculi, I will explain that many patients in whom a CT scan does not show calculi, actually there is calcareous material in the duct, and the ductal diameter has not happened yet, and 65% had dilated ducts as opposed to 86%. More inflammation, that is logical, and there is nearly a half the patients have some form of cysts or disruptions, but pain relief can be achieved equally well in both groups. And bigger stones, bigger ducts, and more pseudocysts in adults. I like to say that calcareous material exists even in the CT, even in CT negative cases. This is a dilated duct in a patient with chronic pancreatitis who incidentally has had several endotherapies. And our present record, as I said last week, is 18 stents. And I really like to discuss with the endoscopist as to what the rationale was. He felt that the duct was not drainable and the patient is free of narcotics after surgery. So this patient was referred to surgery finally. At operation, the duct had so much of calcareous material. The CT scan used to be so sensitive for finding calcareous material. It is not necessarily the case. And sometimes there's soft calculi, less calcium containing, which is very well seen only when you explore the duct. In our practice, there is more large duct disease. When I say large duct disease, duct size over 4 millimeters. More small duct disease and fewer masses in children, and that makes sense. Dr. Balakrishnan, the late Dr. Balakrishnan and Geeta published a small series where they described the etiology of chronic pancreatitis and They looked at mutations, some pancreas divisum, some trauma, and the occasional virus. And they said there was going to be a 5 to 6 year process by which they got into chronic pancreatitis. Surinder Yacha from SGPGI published a larger series where he said 43% only had calculi. And I allude to the previously shown slide where even these people would have calculi. That's my view. A substantial number of these children were low weight in terms of their percentile. They were below the expected normal height and weight, and they were naturally growth retarded in a sense. And over half had genetic mutations, but what that translated into practice is quite a different matter. He said medical therapy was not effective and endoscopic therapy had but modest benefit, but did not talk about surgery whatsoever. If you look at the genetic variants, what the genes tell us, if there's going to be mutation in the PRSS1 gene or the SPINK1 gene, these patients are going to have a slightly more accelerated disease, and so whatever you do has to be more energetic. You have to ask yourself, are we dealing with hereditary pancreatitis? Are we going to consider at some point of time a total pancreatectomy and an islet autotransplantation to rid the patient of the risk of cancer? Or what are we going to do? And that is the main message I get from this. Word about hereditary pancreatitis, which all of us must be aware that it is although it is rare, it is the PRSS1 mutation, and it can occur in families. It's an early chronic pancreatitis, but slow in progression, with a 53-fold risk of cancer. But remember that all forms of chronic pancreatitis, alcoholic is 20-fold risk of cancer, and idiopathic or tropical may have somewhere in between hereditary pancreatitis and idiopathic pancreatitis. Basically, all these genes do is they activate trypsin within the gland and promote the process of inflammation and destruction. If you had to do a total pancreatectomy for these patients, you would have to have a histology positive for chronic pancreatitis. You should have imaging which supports you, documented genetic mutations, and a symptomatic patient with recurrent pain poorly controlled by medications or other interventions. There are other groups which have studied this entity of childhood pancreatitis, and it's tragic that we don't have an Indian representative in this INSPIRE consortium. But what really is brought home is that radiology, which is so eminently good in managing adult pancreatitis, is not really as good in understanding childhood chronic pancreatitis, and especially in the MR, does not tell us all the information. The kappa value, if it's 1, it means good inter-observer variation, and it's often 50% or less, which means in 1 out of 2 cases, the radiologist's opinions differ, and therefore you can understand how confused the clinician will be. So they've actually designed and implemented a study group, and I think some of us should get on board this group. There are a lot of psychological aspects in children which we fail to take into account. Many of them withdraw themselves from school. They have no interest in extracurricular activities. They have anxiety symptoms. They have depressed moods. And they don't adhere to dietary recommendations. And they're worried about hospitalization. And we think that only the adults have psychological problems, but the children do. And the role of psychology in the care of children with pancreatitis is paramount. Nagi would like to say that all these patients can be managed by endoscopy, and in fact his series showed that with a very short follow-up, a good number of these patients can actually go ahead. But in chronic pancreatitis, I'd like to wait several years before I can count my chickens, because this is an episodically symptomatic disease. And in fact, again, I lament the fact that even though the data is overwhelming, still you say it's quite okay to do the endoscopy first up, and cost was mentioned as a cost. Yes, indeed, because most patients who by the time they get to surgery have empty pockets and a body full of narcotics. This is a data from Poland and Europe, and which said that the clinical course of early onset pancreatitis was characterized by more frequent exacerbations and surgical procedures, and indeed that may be the experience of our 121 children, which the youngest patient now is 4 years in this group, which I'm describing, 54 males and 67 females, the youngest being 6 years. Inflammatory lesions such as pseudocysts, pancreatic ascites, and pleural effusions in a very large number. biliary obstructions and inflammatory masses in much less, and of course portal hypertension and diurnal obstruction in a very small number. The treatment was still a fry procedure because of our stated policy of dealing with the head adequately and doing the best the first time up. Although 47 of them had such shortened glands, such atrophic heads, that there was LPJ practically amounted to a fry because there was no pancreas, and it's interesting to see what will happen in the future, whether the rest of the pancreas will develop the disease and force a second procedure. But some patients do require a Whipple procedure, patients who had pseudocysts as well as biliary and duodenal obstruction. And two patients had just a choledochoduodenostomy and no pancreatic procedure. This is an example of a pseudocyst which is not in continuity with the main pancreatic duct, where the end of the jejunal loop was stuck to the pseudocyst. There were no mortality, but complications did occur. And over a median follow-up of over 10 years, pain relief was excellent or good in the majority. What is noteworthy is that there was a marginal worsening of diabetes in the treated patients, but that's maybe as much a part of the disease progression. Steatorrhea worsened because children began to eat well once they were pain-free, and therefore a good number of them required pancreatic enzymes, although it must be said that the vast majority of them could be weaned off pancreatic enzymes, and they were allowed to take enzymes when they had a big meal or when they had a fatty meal. All of them had weight gain universally, and most importantly, children who were in the height and weight percentile chart way below the expectations, they caught up very fast. It could be argued that they were just before their growth spurt and we don't have a comparative arm, but I think they just got better because of the decompression of surgery. The management issues that we faced were that the MRCP did not show us enough information and we had to resort to CT, which meant that more radiation. And a non-dilated ducts with pain was a frequent occurrence, but this group responded eminently to a Frey procedure. So start with the head coring and then the duct discovers itself. And cysts and ductal disruptions are common. And we understand that we recognized in a multidisciplinary forum that cysts and disruptions are the best place to use endotherapy, especially if the ductal burden is less. And it's quite possible that that may be the only intervention required, and that's a small number. But in idiopathic pancreatitis, the question is that you want something for the long term, and repeated endotherapy is neither suitable for the patient's life or nor his or her purse. So in conclusion of the group of patients, our group, we said that surgery in children with tropical pancreatitis provided relief of pain, amelioration of complications, and restoration of normal growth. And it may help prevent growth retardation and preserve pancreatic function. I'm very delighted to present to you some Calcutta experience from the Postgraduate Institute of Medical Education and Research, and Dr. Ray, who sent this article to me a few years ago. He was so kind to do so, 2 years ago, in fact. And he has very similar experiences, except that he used an IASGCON procedure in 3, and I wondered if we had talked to each other and he had tried to do the Frey in those cases, he may have been able to avoid the IASGCON, because the duct can always be found. This is a child with chronic pancreatitis in whom the duct could be discovered. You can see that the pancreas is very small, the patient is very small, but the duct discovers itself on coring the head. So I would like to conclude by saying that there are differences in approach to the childhood pancreatitis in terms of we need to monitor the growth and pubertal development, the dietary intake and deficiencies of macro and micronutrients and bone mineral density, which are a big issue in these cases. Do genetic studies, and if there are mutations are present, then we energetic approach to those with mutations. Vigorous use of pancreatic exocrine replacement therapy, because that's the next best thing you can do to minimize growth retardation. Yearly monitoring of glucose tolerance. There is, as such, no evidence to support antioxidant use. I would use endoscopic therapy only in pancreatic ductal disruptions and that as a temporizing measure. And early surgical intervention may reverse growth retardation. Thank you very much.
Thank you, Dr. Ramesh. Now session is open for questions.
Sir, I have a question. Nice talk, sir. In your series of 120 patients, in what proportion genetic studies were done? And if you are done in selected patients, like how will you decide in this group of patients I do a genetic test?
All the patients underwent genetic studies. 44 had SPINK1 mutations. none had a PRRS1 mutation. And we are now embarked on a larger study to try and see what the controls will have, what the SPINK1 value in the N34S mutation will be present in controls, because I understand that the SPINK1 mutation can be very well present in normal population as well, and may not have an implication on the development of pancreatitis. So we haven't changed our strategy. We have only treated the pancreatitis as an idiopathic or tropical pancreatitis, and maybe we are not doing enough, but I'm not sure. She was first.
Please, yours.
Thank you. Sir, in this large series of children with pediatric, the younger age pancreatitis group, most of them had phrase procedures. How do they behave post-phrase compared to the adult population? Thus, they are undergoing a phrase in a very early age. In most of our series, this pain usually comes back, at least for with a lesser intensity in most of the patients in adult patients underwent phrase procedure. How do children behave in the post-phrase?
I just took exception to that statement saying that invariably the pain comes back, and I contest that fact. But in children, it's early days yet. 10 years is not enough, because many of these children have only reached their teens. And as I said, in chronic pancreatitis, you have to follow these patients up for life if you're going to get any meaningful answers. But we must remember that the fry in the 6-year-old is a very small fry, because the pancreas is so tiny, and the amount of pancreas removed is very small. The end effect is the same, that you have achieved drainage of the head, but I think you will just have to wait and see. But for 10 years, you find that patients are doing very well. They have achieved their growth spurt. They have doing well with their studies or with whatever they're doing in life. So let's wait and see.
So how can we plan our next step? If they come back with pain, maybe they are 10 years.
Well, that's a different ball game altogether. If pain returns, then we have an algorithm. We first say, is the patient developing other diseases, upper abdominal diseases like peptic ulcer, which is a common accompaniment of chronic pancreatitis because of the unopposed action of acid and the low pancreatic enzyme output? Or does the patient as teenagers started smoking, and if that is smoking related? Or is there, then I would go on to a cross-sectional imaging to know if there's an inflammatory mass, is it cancer, is there any area of the pancreas which has not been drained adequately in the form of a cyst or an inflammatory mass, and then I would then use endotherapy. Endotherapy would then divide patients into those where the pancreatogegenostomy is pacified by the endoscopist, which means that that path is kind of open. Then you can use ESWL and clear any residual calculi, and even stent unstenotic process ducts if they have not been incompletely drained. And if they don't, then even a re-head coring has been done in a substantial number of our patients. So the key was to know that we have not done enough for various reasons. So all of this algorithm would then be employed.
Thank you.
Sir, would request you to throw some additional light on two aspects. One is, you said there's a 53-fold higher risk of malignancy in hereditary pancreatitis. So that seems a very scary. So what should be the management in that? And so second thing is, your experience, any of an operation we always try and avoid, that is total pancreatectomy. Any experience in adults or the other ways?
Well, most of the total pancreatectomy has happened in IPMNs and not in chronic pancreatitis. I have myself been reluctant to do total pancreatectomy except as a salvage procedure. But as far as hereditary pancreatitis is concerned, it's fairly rare in India. It's more a disease of the West, but you have to keep an eye out for it. If you have a childhood pancreatitis, we must ask ourselves these questions. A, is it hereditary pancreatitis? If it is not, then is it idiopathic pancreatitis of the tropical variety? Is there a genetic basis? It's not that if you have a PRRS1 mutation, you're immediately going to take the pancreas out. It doesn't make sense. Because 53-fold risk is not that big a risk, although it sounds scary. But a careful watch will be required. If the patients invariably become symptomatic as well, and by the teens, they drive you to a procedure. And if there is if there's a multiple gene mutation, as I showed in my slide, if you have more than 2 genes, mutations, then that is the case where probably a total pancreatectomy would be an option, and an islet cell autotransplantation.
Just one question, sir. Mohan from Madurai. Recently we had 2-3 children who had chronic pancreatitis, symptomatologically planned for surgery, and we found that most of the times we are concentrating on head and bulk of stone in the head, but the tail is not addressed properly. That is what I was thinking, that if there is a lot of stones or pseudocyst in the tail, what is the take, whether do a distal pancreatectomy along with it, or?
If you look at the case, the operation list, there were a few distal pancreatectomy, 5 I think, but I'm sorry we did them, because I feel that if you mobilize the tail of the pancreas carefully, you could easily do a conservative operation, considering the magnitude of islets in the tail. If my next patient, they would not definitely undergo a distal pancreatectomy unless I had no choice, unless no other technical option. But 40% of idiopathic or tropical pancreatitis in our hands has body or tail disease. And that's why we propose that the fry is the solution rather than a beggar, because the beggar does not deal with it. And that's the basis of our recommendation for a fry procedure. So I absolutely agree that body and tail would have to be dealt with the same amount of care and thoroughness as you would do the head.
Because many of times the failures or recurrence of pain, we found that the tail has not been dealt with.
Well, that's your experience, but as the numbers keep mounting, I'm sure the head will again the head is much more difficult to deal with. Therefore, even if you are very careful, you would still not do enough. And therefore, I feel that in the long run, you would find the head is still the culprit, but I agree that sometimes people would not realize that there is much more tail left. So I keep emphasizing the importance of correlating the preoperative imaging with the intraoperative findings. Very often, surgeons overlook the fact that there is a large stone near the end of the tail, and they haven't even cleared that. Actually, stones indicate where there is a stricture and stasis. So if they had only cleared that then the Mohan syndrome would not have happened. So it's just the attention to detail which is the key here.
You were a strong proponent of using C-arm intraop to...
Well, it's very difficult sometimes because the C-arm, unless you keep a very low kV, you have MA and kV in the C-arm. You have to drive the kV down. Otherwise, the less calcium stones will not be seen. But if you do keep the kV down and then run the C-arm, you will be amazed that you will see many things which you don't see otherwise. It's almost like a soft tissue X-ray, a mammogram type of a picture. And you can then correlate, you have the CT on the console, on the screen, computer screen, and you have this, and you appreciate, or your resident will easily tell you that you haven't cleared this area. And then you can go back and dig, and you will usually strike pay dirt.
Thank you, sir.
Sir, any suggestions or help, intraop ultrasound will help to rule out any calcification in the tail, specifically when we are missing out on the C-arm or something?
I am not sure if it will help. I think we have excellent preoperative imaging, if you can keep that as a guide. And then if you mobilize the pancreas, and most of my videos have emphasized that the operation consists of basically mobilization. If you mobilize the lower and upper border of the pancreas and take it all the way to the tail, you'll be surprised that the whole organ seems to jettison itself from the retroperitoneum. And then it's pretty much a child's play, if you like, to lay it open, to dissect it, to do whatever you like. But if you don't do that, then it's stuck in the retroperitoneum, and its margins are not clear, then you even tend to sort of linger onto one side or tread onto one side and even injure the splenic vessels or the splenic vein. All of that can happen. So I would recommend that if you mobilize it well enough, I don't think an intraoperative ultrasound is required.
Thank you, sir.
Thank you, Dr. Ramesh.